Raybaud, che è responsabile neuroradiologo al Sick Children Hospital di Toronto e autore di numerosi lavori molto importanti, molti dei quali con correlazione anatomopatologica.
Thank you very much. I want to thank the organizers of the meeting and Professor Valentini for inviting me here. Dr. Durocco gave a good relation of all the controversies concerning the various types of Chiari malformation, Chiari 1, 2, 3, and 4 malformations. I'm going to try to give you a simple idea of what I think of the development of that part of the body is, and it may sound very presumptuous to you, but I mean, I think without a simple idea, we cannot have a hypothesis and we cannot check, and it's always better to start from a simple idea, even if it's to acknowledge later on that the idea is wrong. Anyway, the spine includes, not the spines, but the somatic axial skeleton includes what we call the spine, but it also includes the posterior fossa, the bony posterior fossa. Basically, the bony posterior fossa is made in the same way as the spine is made, from the notochord. And the cranial vertebral junction is a structure that is functionally dedicated to the motion of the head and prehension of food and smelling and whatever. So I think it's a very special structure. We tend to call the posterior fossa on one hand and the spine on the other hand. I would personally recommend to use the posterior fossa, the cranial vertebral junction, and the spine as three different structures. There is a specification, secondary specification, of course, of the spine, at least in the human being, in which you have the standard basic vertebra develops as a cervical, thoracic, lumbar, sacral, and even coccygeal rudimentary vertebrae. So I think this is important to remember. The second thing that I think is important, maybe I can use this rather. The second thing that is important to remember is that what is called the hindbrain, including the pons and cerebellum, fourth ventricle, and medulla, are totally included in the posterior fossa. I don't know, I think it's the same thing in Italian. In French, we call the medulla the bulbe rachidien, meaning that actually this part of the brainstem is across the foramen magnum. But that's true in cadavers, not in living people. And the medulla actually is entirely contained into the posterior fossa. So that's important to remember that if we want to analyze the malformations associated with the brain malformation associated with the posterior fossa or the spinal malformation. I am not going to talk about the anatomy, it will be too long. I just want to stress that we have several levels. We have the posterior fossa that is there. We have C1, and here we have a very compound structure made of the ossiculum terminali, the dens, and the body of C2, with C2, and then the normal spine. On the coronal cut, it's very important to remember that the occipital bone at this level is made of the jugular tubercles that are abutting the petrous bone in front of the jugular foramina, and we have a huge occipital condyles. And then we have the lateral masses of the atlas, and then we have the C2 with the dens. So just to say that this is very important because that makes the thickness of the bony structures on which the spine is attached. The craniovertebral junction, if we consider the malformations of the craniovertebral junction, we have to consider both the development of the bone and the development of the neural tube. And we are going to start with the neural tube because it's the simplest and we are most familiar with it as neuroradiologists. The first process is the gastrulation, in which you have the formation of the mesoderm that develops from the ectoderm by insinuating itself between the ectoderm and the endoderm. Along the midline, that makes up the notochord. On each side of the midline, it makes up the somites, which are small masses of para-axial mesoderm, which represent the segmentation of the body as it appears in worms, for example. So we have two very important things, the axial mesoderms and the segmental paraxial mesoderm. The somites are segmental, and we will see that to produce the spine, it has to become intersegmental. And that's where the story becomes a little bit more complex. Because the start of everything is the notochord that induces both the spine and the neural tube. If you have a disorder of the notochord, then you may have a disorder of both together, simultaneously, of both the neural tube and the spine. This occurs when you have neuroenteric canal and cysts. I have seen two in my life at that level. And it happens also in the literature. I've never seen a case of duplication of the posterior fossa in the same way as you have a diastematomyelin. It does exist in the literature. I have never seen a case. It's certainly extremely exceptional. In those cases, of course, the neural tube and the spine and bony posterior fossa are abnormal together. Besides that, beyond that, I think the development of the spine and the development of the neural tube are independent, and therefore the malformation may be associated, but they are not causally related. I think yes, okay. Oh, I'm sorry, I was on the wrong side. Okay, the notochord and, send signals to the ectoderm so that it forms the neural tube, neural plate first, and then the neural tube, and the neural tube below the posterior fossa becomes the spinal cord. So that's the important thing, and that is produced through a process of closure. That means that if you have a failed closure of the neural tube, so-called neural tube defect, then you may have a malformation, and that happens at the level of the craniocervical junction. It is called the Chiari-3 malformation. The definition of Chiari-3 has been extended to the occipital meningoencephalocele. I disagree with that because it's not the same thing. Basically, the Chiari-3 malformation happens because there is a disorder of the closure at this level between the midbrain and the upper C-spine and the upper cord. Basically, the Chiari-3 is the same thing as a myelomeningocele, except that it is located at craniovertebral junction. It produces an encephalomeningocele. Of course, because there is no closure of the neural tube, there is no closure of the bone around it. That means that you have together a bony opening posteriorly and the malformation of the neural tube. That's the Chiari-3 malformation, not very common. Chiari-2. I think now it has been well demonstrated since the work of David McClone in Chicago that the Chiari-2 is a secondary. It's not a malformation in itself. It's a deformity that is secondary to the neural tube defect. Usually that's a spinal myelomeningocele. It may be an anterior rostral encephalomeningocele, and it is related to the fact that you have a leak of CSF. Because there is a leak of CSF, the rhomoencephalic vesicle doesn't expand, therefore the posterior fossa remains small, and when the brain, the hindbrain, develops into the small posterior fossa, it overflows its capacity and herniates superiorly, as was mentioned by Dr. Di Rocco, and herniates inferiorly. The brainstem typically is down into the cervical canal because the posterior fossa is too small. What is interesting, some people have talked about overexpression of the dorsalizing genes. But the problem is that if you correct that before 25 weeks, you tend to repair the Chiari-2 deformity. That means that it is really an early mechanical complication of the myelomeningocele. And basically, except for the size of the posterior fossa, there is no abnormality of the bone. Chiari-1 is unrelated. Both Chiari-2 and Chiari-3 are related to the same type of genetic and environmental factors. But Chiari-1 is probably completely different. In my opinion, there is no difference between the tonsillar herniation in the posterior fossa tumor and a Chiari-1 malformation. It is, you say that it was a disproportion between the content and the container. It may be related to some abnormal hydrodynamics if the anatomy is favoring, like lomboperitoneal shunt, for example, but also any time when there is an overdrainage of CSF, before you have any bony changes, you still may have carry-1 malformation. The most common occurrence is in a small posterior fossa or small cranial contents, and it may be also when you have a large one, developmentally large brain. I will talk afterward about what I call the pseudo-carry. So those are cases of herniated tonsils that can be called a carry-1. This is in the case of overdrainage of the CSF in patient with hydrocephalus, and then it developed progressively the peg of tonsil into the canal. It has been well described in the context of vein of Galen. In this case, I think you may have the mass effect of the veins, but also it has been demonstrated that the venous congestion was leading to herniation and relieving the venous congestion, even though the mass of the aneurysm may remain the same, then the cerebellum may come up. In the cruson, when the skull is too small, when you have an early ossification of the lambdoid suture, you may have the development of a carry-1, like in this case of cruson. There was no carry-1 at birth. The carry-1 appeared later, and Giuseppe Cinali demonstrated that in most of the cases of cruson, it was related to the early closure of the lambdoid suture. This was in the case of oxycephaly. This was in the case of thalassemia. That means that the primary bony change led to the development of the carry-1. That means that it is really mechanical. And then you may have a large brain, like in about 10% of the NF1 patients, you have carry-1, and in Proteus syndrome, which also associated with the megalencephaly, you have a carry-1. So basically, it is what you call the disproportion or the discrepancy between the size of the content and the container. Now we go to another type of carry-1, or usually called carry-1 malformation, which is related to the malformation of the craniovertebral junction. That's very important. When I was a young student in neuroradiology, people told me that actually carry-1 malformation was associated with the craniovertebral junction malformation. I don't think it's a real carry-1. So we are going to look a little bit at the embryology of the craniovertebral junction. So basically, we have seen the neurolocation side, looking at the spinal formation side. The notochord and the somites together through the sclerotomes form the vertebral center. The vertebral center and the neural tube induce the formation of the neural arches. That means that basically the neural arch is secondary to the cord malformation, to the cord development, and partly also of the vertebral development. Basically, the somites are segmental structures. That means that it corresponds to the sensorimotor metameres. That means that the nerve is leaving the cord at the level of the somites, because it goes to the metamere. Okay? That means that if you want to develop vertebrae from the sclerotomes, you have to develop the vertebrae in between the nerves. And because you develop the vertebrae in between the nerves, you have the process of resegmentation of the somites. But this segmentation concerns the spine from C3 down, but not above. I mean that the posterior fossa, the bony posterior fossa, is not resegmented. It remains fused from the beginning, and the craniovertebral junction has to evolve functionally as the tool to move the head and to seize the food, etc. So the development at this level is very specific. So basically, the somites, the sclerotomes and the somites, are made of a loose cranial part and a dense caudal part. And in between, there is something that is called the fissure of Ebner that develops so that finally the vertebrae will be made of a dense caudal part and a dense cranial part, rostral part, and a loose caudal part. This process involves the genes, segmentation genes, and necessarily is a relatively complex process. And because of this relatively complex process, you may have many malformations, and you know that the mosaic spine and so on are fairly common. It is still more complex at the level of the craniovertebral junction, because basically the posterior fossa remains segmented, and actually the craniovertebral junction itself remains segmented. But it is resegmented between the occiput and the craniovertebral junction, but it remains fused for C1 and C2, and then it becomes normally segmented below. So here the signals are complex, and because they are still more complex, you have still more complications. Basically, the somite, we are not talking about somites, we are not talking about vertebrae. The somites, the occipital somite 1 and 2 form the basic occiput below the syncodrosis there. Basically, O3 makes up the posterior part of the occipital bone. O4 is divided in two because there is a separation, ulnar cleft, in between the rostral and the caudal portion, so that you have a resegmentation there. But then, between O4 and C1, there is no resegmentation, which is normal, but there is no resegmentation also between the rostral and the caudal part of C1. And then starting at the level of C2, then you have the segmentation again. Okay? So, starting from this, you can develop the whole pathology of that area. So, somite O1, O2, and O3 basically are not divided. O4, the proatlas, is divided between the loose rostral part and the dense caudal part. Normal process. But the first cervical somite is not divided, and then the other ones divide normally. And of course, you have the articulation between the anterior part of C1, but that would be another story. Okay, what can happen? Any of the somites can be involved. The most common malformations are the hypoplasia or aplasia of the somite, occipital somite 1 and 2. In that case, you have the so-called small, short clivus. Okay? If you have a short clivus, the craniovertebral junction is too high, but the neural tube is normal. The cerebellum is the normal position. That means that the craniovertebral junction is located too high in relation to the posterior fossa content. And you call that, everybody calls that a carry one, but it's not a carry one. The posterior fossa is normal. What is not, the content of the posterior fossa is normal. What is not normal is the level of the articulation. The level of the joint is abnormal. And I guess because of that, the treatment, the surgical treatment of this pathology is especially difficult because we are not dealing with the usual carry one malformation. But if you look here, look at the level of the junction. The junction is at the upper level of the medulla, not at the level of the medullary cord junction. Second thing, when the fourth occipital somite is hypoplastic also, and you recognize that because look how small it is here. We saw before it was a very high structure. Here it's a very short structure, and because it's a short structure again, the craniovertebral junction is again too high, and therefore the tonsils are too low. I call that a pseudocarry because the position of the tonsils in relation to the medulla is a normal position. And then the other malformation, but it's not associated with abnormality, let's say, of the cerebellum, is the aplasia of the head. But in those two cases, the rotation of the head is too high. That may compromise the medulla, and not the craniovertebral junction of the cord. I mean, the medullary cord junction. It compromises the medulla itself. So I call that not a carry one, but a pseudo-carry. The other malformations are much simpler. It is when the segmentation is abnormal. If it affects the fourth occipital condyle, then you may have, if there is a division too high, then you have what is called the condylus tertius, the third occipital condyle. If on the opposite, the proatlas remains fused, then you have the so-called assimilation of the atlas. And if there is a division, there shouldn't be any division between C1 and O4. If the division remains, then you have the ossiculum terminali. And below, if the fissure between the C1, the rostral, and the caudal C1 persists, then you have the os odontoidum. But in those cases, of course, you have no reason to have a Chiari 1 or something that looks like a Chiari 1 malformation. So to conclude, except for the major early malformations of the posterior fossa and upper cervical spine, and the very uncommon Chiari 3, the bone and the neural tube develop separately, and the craniovertebral junction and the hand malformations are independent. Chiari 3 is a malformation, Chiari 2 results from a malformation, and Chiari 1 is purely mechanical or related to an abnormal anatomy initially. When the craniovertebral junction is displaced rostrally, then you have a pseudo Chiari 1 malformation, and basically the craniovertebral junction anomalies are related to the extreme complexity of the development of this structure. Thank you very much.
Thank you very much, Charles. We'll have a discussion at the end of the session.